I'm glad that everyone can make it on a busy Wednesday afternoon. I'm sure all of you have a lot of things in your schedule, on your plates, and I certainly welcome all of you for, again, taking the time to be here to hear what I have to say today. We're talking about pregnancy and pregnancy planning in the era of COVID-19, and I think this is a very important topic because there's so much information, and at the same time, there's so much disinformation that we are seeing on social media, on the regular media, news outlets, medical information, and so on. And I think it's important to clarify some of what we're hearing and some of what we're seeing so that we as the informed public can make better decisions about what to do with our health care. So this is who I am, and I am a practicing obstetrician gynecologist here in Mission Viejo, California. I also practice functional and integrative medicine, and that is a little bit of a different branch off from the traditional Western medicine that I've incorporated into the practice that I have, and it also, again, does allow me to do different things for patients than a traditional Western medicine doctor can do. I've been here about 30 years in the Mission Viejo area, and so I've seen a lot of things kind of come and go, and this COVID-19 is probably one of the most important and significantly life-changing events we've had in the practice of medicine, locally at least, again, since I've been here. I think that when we have a discussion about COVID-19 and pregnancy, the first thing we have to do is kind of take a few steps backwards and discuss, what is COVID-19? And certainly it's a virus, and of course, well, what's a virus? And it sounds like a simple question, but for a lot of people, if you ask them what a virus is, they kind of understand what the concept of a virus is, but they don't really know what a virus is. And a virus basically is a very simple living organism that contains some form of DNA or RNA inside of its nucleus, or inside the center, I should say, of the virus, surrounded by a protein coat or a protein capsule of some sort. So it's very simple, and it's so simple that it cannot even reproduce itself. These viruses have to go inside of another living organism to make more viruses. So that's how simple they really are. Very, very, very small molecules. In fact, they're so small that you can't not see them with the naked eye. You cannot see them with a light microscope. So if you're looking under a microscope, you cannot see a virus. They were first actually discovered in the late 1800s and were not seen until 1931. And the first discovery wasn't actually because somebody saw the virus, but they did an experiment looking at tobacco, a mosaic virus, and was able to show the transfer of this potential destructive organism to another tobacco plant, and they presumed it was due to a organism, and they named it a virus. So it's been around for a long time, our knowledge of it, and it's really seeing it since 1931. So we've had a lot of experience with viruses. If we look at the coronavirus in particular, most coronaviruses are very species specific. So they really tend to exist within certain animal groups, such as bats or dogs, or in cases of Southeast Asia, palm civets. And they generally stay within those animal groups. So a coronavirus that, for example, may infect bats primarily will not usually infect dogs, or will not infect birds or other animals that may live in very close proximity to those bats. There are some viruses that are less species specific, and they tend to transfer between different animal groups quite readily. Coronaviruses in general are very species specific, and there are some mutations that occur in some of the virus families that allow them to make these jumps from one species to another. In the, again, coronavirus family in humans, there's about 7 of these viruses that are really pretty much limited to humans. But in the wild, there are literally hundreds of coronaviruses found through multiple different species, again, throughout the world. In general, the infections are mild, would be very similar to what one might experience with a common cold. So it's possible that you could have had a coronavirus, not the current COVID-19, but a different one of the human 7 virus types that could have infected you last year or the year before last. And you might have had some sniffles, maybe a little bit of a sore throat, maybe a little bit of a headache. And then it resolved after a couple of days, and you might have assumed that you had one of the other common viruses, such as a RSV virus or a other type of, again, viral infection that, again, commonly infects people during the wintertime, such as the rhinoviruses. but it could have been a coronavirus. What makes coronaviruses particularly interesting and at the same time dangerous is that when they make the jump from animals to humans, we call those zoonotic jumps, they're changing species. And sometimes that change in species can be quite deadly. SARS was one of these first zoonotic jumps that we saw with coronaviruses, and this occurred around 2002, 2003. And it occurred, again, very little in the United States, but worldwide there were about 8,000 cases. And it was associated at that time with about a 10% mortality rate. And they had close to 800 deaths. And it started in southern China, and it worked its way around some parts of Southeast Asia. And they were able to contain it quite readily, primarily by realizing that it did have some ability to go from human to human, not like our current SARS virus does, but again, did have some ability to go from human to human. So by simple measures of masking and protective clothing, they were able to really knock this down, and also doing a lot of contact evaluations and keeping people indoors who had been exposed. They got this under control quite quickly. The next coronavirus that jumped was the MERS virus, and that one's the Middle East respiratory virus. And that one was found primarily in the Middle East, hence the name. And it was also found to jump from animals to humans, and it came from the camel. But because, again, it was primarily camel-oriented, there were not a lot of human exposures. So in general, there was about 2,500 people had got infected by that virus, but it was a much deadlier virus than the initial SARS virus was in 2002. So this virus killed about 30 to 35% of the people that were infected by this virus. But because there was such a small number of people infected and it was so easy to contain, it never really got to the point of being a true pandemic. We then have our current SARS virus, and it's SARS-2 because the first one was SARS-1, and that stands for Severe Acute Respiratory Syndrome. And as the name implies, it infects the respiratory tract primarily. The COVID stands for coronavirus, and ID is for infectious disease, and the 19 is for the year that it came about in 2019. So COVID-19 actually was a name that was given to this virus by the World Health Organization, but typically speaking, that would not be the name of this virus. We'd be calling it SARS-2. But I think that most of the people out there felt more comfortable calling it COVID-19. I think a lot of people would be confusing SARS-2 with SARS-1, so they just gave it a slightly different name. Now, one of the common problems that we run into is how do viruses get transmitted, and is a virus transmitted easily or more difficultly depending on the virus type? Well, first of all, in order to get the virus, it has to be transmitted to an acceptable host. So in order for me to get a virus, that virus has to have a way of attaching to some of my cells or getting into my cells to reproduce. And because most of these viruses are very species specific, it can be very difficult for most viruses that are not already in humans to be able to get to me and be able to attach to my cells, because there are certain proteins or receptors that are not able to cross-react with the virus to allow them to attach. You also need to have entry into the body. And certainly these respiratory viruses really prefer to get into the body via the respiratory tract. So that's through your nose, into your mouth, into your lungs. And so that's how they prefer it into the body. They can also enter through your eyes, of course, through any moist mucous membrane. But in general, they're going to prefer going into the body through an open cavity such as the mouth or the nose. You're not going to get the virus to infect you by landing on your skin. So that the concept that the virus being on your arm or the virus being on your leg is some sort of a dangerous event, it really isn't. You're not going to get the virus that way. Next, the virus has to enter into the cells. So once it gets into your body, it gets into your nose, into your lungs, it then has to be able to proceed from there and attach to one of your cells to be able to infect it and to inject its nucleic acids, either RNA or DNA, which is the genetic material that allows the host cell to produce more viral particles. The virus has to be able to hook on, kind of like the space station that's circling the Earth. We can send a rocket into space to attach to it, but unless there's a specific locking mechanism that allows that space station and that capsule to lock into each other, you'd be unable to get astronauts to go between the docking pod and the space station. Well, the same is true with the virus. There has to be some sort of a locking mechanism that allows that virus to attach to the cell that then allows the virus to inject its material into the cell. Not only do you need to have this virus present in the Baginski cavity, the receptors present, but there has to be enough particles present. So again, if I give somebody one viral particle, that viral particle is not going to create a disease. And for some viruses, it requires a lot of viral particles to actually overwhelm the host's initial immune response to create disease in that individual. So you need to have the viral particles in sufficient quantity and sufficient location, the acceptable host. And again, if you have poor host immunity, you need less viral particles. So that's always an ongoing kind of an equation. The lower the host immunity, meaning the ability of the person to fight infection, then the less viral particles that are necessary. Likewise, if the host has a very strong immune system, then you require many more viral particles. The last one is the ability to replicate and spread. So once the virus is in there in enough of a quantity, they then have to be able to replicate. And if the host machinery is inadequate for it to replicate, or if the virus, for whatever reason, cannot replicate inside that host, it's not going to spread anywhere. So again, it has to be able to make more viral particles and then get out of the host. Now, what happens with COVID, it reproduces, it gets into the lungs, and then the host coughs it out or spits it out, and then allows it to spread. So who's at risk for getting this infection? Well, we know that everybody can get COVID. It's not a matter of there's any particular group out there that is immune to getting COVID infection. But some groups are more likely to get COVID infection because of certain characteristics, and one of those is age. So we know that we use the term elderly as greater than 60, and I take great umbrage to that term since I'm over 60 myself, and I don't consider myself elderly. But nevertheless, realistically speaking, I have to realize that my immune system is not the same as it was when I was 30 or 20 or 19. And because of my immune system not being quite as good as it was, I am to some degree immunocompromised. So that's why when they talk about the elderly as being greater than 60, it's not because these are old folks, but they know that the immune system for these older people is not as effective at clearing these viral particles as it is in somebody that's younger. Therefore, it requires fewer viral particles. So now they're at risk to getting an infection easier than somebody who's younger. Immunocompromised is another whole group of people, and a lot of these individuals who are immunocompromised might be people who are on medications for organ transplant or for fighting things like rheumatoid arthritis or lupus, or have other common issues related to their immune system that may be making them less likely to be able to combat a viral infection. People with pulmonary disease, another setup. Why? Because the lungs become inflamed. There's issues with lung and air movement, so it's more likely that these air particles will get trapped in the lungs and have a greater, or I should say viral particles will get trapped in the lungs and have a easier time attaching to the lung cells and allowing them to infect the lung cells. Underlying medical conditions, likewise, hypertension, obesity, and the reason why obesity seems to be one of these at-risk groups is because typically obesity is related to an underlying inflammatory process in the body. So if someone has excess weight on their body, typically they're going to have more inflammation occurring in their body, and whether that inflammation is in the cardiovascular system, whether it's in the fat itself, whether it's in the intestinal tract, this increased inflammation also causes them to be more immunocompromised. And the last group, of course, is pregnancy, and that's what this conversation will be kind of focusing on towards the end, is about pregnancy and this at-risk group. Part of the reason why pregnancy is at risk is because the act of becoming pregnant is somewhat of an immunocompromised state, so that the body does not reject the implanting embryo. And at the same time, as a woman gets further in her pregnancy, she will have compression of her lungs because of the growing fetus inside the uterus, and that compression of the lungs basically creates compressive pulmonary disease. So you have more difficulty breathing, more getting out of breath, more compression of lungs, and issues related to fluid in the lungs. So again, this process of being pregnant creates a little bit of immunocompromised pulmonary issue for patients, and so that puts them to the higher risk group. So what I hear a lot, or was hearing a lot, was people talking about, the vaccine and the fact that COVID has swept through millions of people. We've heard about the comment that people make called herd immunity, all these wonderful things, and everyone's of the idea that, okay, now it's all over with. We can kind of take a nice deep breath and a sigh of relief, and we no longer have to worry about future infections and the need for any vaccinations any further because we're all set and we're all done and we all have herd immunity. Well, I wish that were true, and I think that with coronavirus in particular, that won't be the case, and it may never be the case, but the reason why, in part, is because we're dealing with these variants. And what variants are is they are viruses that have mutated, and different families of viruses, different types of viruses will mutate at different rates. So there's a background rate of viral mutation. And sometimes there's excessive pressure placed on these viruses to mutate. And so what they do is they begin to mutate quite rapidly. And COVID viruses in general, have the capacity to mutate. In fact, they can mutate quite quickly. These ongoing mutations really are the virus's way of trying to defeat us. So this is truly an us versus them scenario. The virus wants us to utilize our machinery for reproduction only, and of course we want nothing to do with those viruses. So in order for them to kind of keep around and stay alive, every time our body fights these viruses successfully and creates good immunity, the virus tries to change something about its protein code, something about its spike protein, doing something to evade our immune system and to stay alive and allow it to produce more of itself. The ability to jump species also has allowed these variants now to be able to move quite readily between different animal groups. So not only are these COVID-19 viruses attacking humans in great numbers, but also they're now going into dogs and cats, birds. So these mutations have allowed these viruses to become more, or this virus in particular, to become more of a generalist. And this ease of spreading now is the hallmark really of COVID-19. So how bad is COVID? And again, I've been hearing different comments over the past year and a half from various sources, and it's not as bad as the flu. Oh, it's just like the flu. Oh, let's not worry about it. It's not a big deal. So let's take a look at the real numbers. If you go back to 1918, the year that Arthur Eddington started to put into play the proof for Albert Einstein's theory of relativity, also the time of World War I, there were 600,000 U.S. deaths from the Spanish flu, and there were millions worldwide. So this was truly a large pandemic, and this was influenza. This was, I believe it was the H1N1 strain of the flu. The Asian flu, 1957, 70,000 deaths in the U.S. 1957 is an interesting year because that was the year that the Russians actually launched the first space satellite known as Sputnik. That was 1957, and that actually started the whole war into space between the Russians and the U.S. as who could be the first into space and land on the moon. Hong Kong flu, 1968, 34,000 deaths in the U.S. So again, that was another pandemic with the Hong Kong flu. 1968, that was a great year for me because that was the year that the Detroit Tigers defeated the St. Louis Cardinals in the World Series. Then we look at seasonal deaths from the seasonal flu. These are non-pandemic flus. This is here in the U.S., 2010 to 2020. Averaging about 32,000 deaths per year, not a small number. So in those 10 years, there are 320,000 deaths roughly between 2010 and 2020. That's the U.S. flu. COVID-19, since its onset in early 2020, we've got over 646,000 deaths, and that number is climbing every day. So this is not a stagnant number. This is not a static number. This is a number that keeps on increasing. Worldwide, with the coronavirus, we've had over 4.5 million deaths worldwide. And again, that number is also no longer static and it continues to go up. So how bad is COVID-19? If you look at what we've had so far, it's pretty bad. Now, how do we prevent the infection? And again, I'm raising topics here to kind of cover things that I get in my practice, questions that are asked to me. things that I hear on the media, things that I hear from influencers, from both social media and the regular media outlets. So let's review those. So to prevent infection, they talk about hand washing and gloves. Well, hand washing, cleaning things off your fingers has a value because your hands touch a lot of objects. And if someone were to cough or sneeze and have their spit or their sputum land on something that you were then to touch with your hands, that by itself does not cause infection. You would then have to take your hand and touch a mucous membrane, something that's moist, like the inside of your mouth or your eye, that would allow this living viral particle to go from the surface of what was touched onto your hand, then onto that mucous membrane. So if you don't touch any mucous membranes with your hands, then you're very unlikely to spread that infection, especially a virus. Now, the same may not be so true with bacteria because they can live much longer on surfaces than viruses can. But nevertheless, it's a tough way to spread a virus. But we have a lot of discussion about hand washing. Physical distancing, also very popular. If you went to any stores like Costco in the last year, you would have seen little circles on the floor with little sayings on it, like we're all in this together, let's stay as a team, teamwork, team spirit, all these things, keep your distance, blah, blah, blah. And they're talking about 6 feet. Again, a very interesting number because it's never really been tested whether 6 feet or 8 feet or 10 feet is the right distance. And what they're really trying to prevent from physical distancing is the droplet transmission of viruses. So if you were to cough, if you were to sneeze, even somebody talking, as I talk here right now, I actually have microscopic droplets of my saliva. It sounds disgusting, but of my saliva going out in front of me, and they're going to travel a certain distance, and then they're going to drop down because, of course, of their weight. And the larger the droplet, the shorter distance it's going to travel. So they kind of said, well, maybe about 6 feet should be far enough for this droplet to not make it to the next person. Well, that's okay for droplets, but if you cough or sneeze, those droplets are going a lot further than 6 feet. They'll be going 10, 20, 30 feet easily, again, with a good hard sneeze or a good hard cough. What they're not talking about is the aerosolization of the virus. So as I'm talking, even as I'm not producing a lot of spit or a lot of droplet excretions, I still have air that's coming out of my mouth, and it's going out around me, and it's circulating around me as well. That air is also going to be carrying viral particles because there's moisture in that air. So it's that aerosolized air that's going to go further than 6 feet. So again, that distancing, okay, maybe for droplets, not so much for aerosol air. Crowd control, that's important because if you get a lot of people together in the same place, you're increasing the chances that somebody has the infection is going to spread it to people around them. And the closer the people are in that crowd, the more likely you're going to see that infection spread. And this has been borne out numerous times by evaluations of large groups of people who've gotten together and then looking at the infection rate post these congregations. Virus dilution, outdoors versus indoors. Clearly, the safest place to be during a viral pandemic is outside. And the reason why is because any form of transmission is going to be reduced by being out in the outdoors, whether it's coughing or sneezing, whether it's aerosolization, whether it's contact, everything outdoors will reduce that risk. But it doesn't mean that just because you're outdoors, you can have a large gathering of 100,000 people packed in shoulder to shoulder, and you've now taken away that risk because you're outside. Again, you have to use common sense, but outdoors is better than indoors. Face coverings. Face coverings is very controversial. There's been a lot of discussion of face coverings. I'll only let you know, I'll break it down to the real simple facts. The facts are N95 is better than surgical mask, better than cloth mask, which is better than nothing. So I would look at a cloth mask as a seat belt, like a lap belt. I would look at a surgical mask as a shoulder constraint. I would look at a N95 mask as airbags. So if you want to be the safest and reduce the amount of exposure the greatest, you're going to have an N95 mask on, and that's whether you're somebody who's worried about transmitting it or someone who's worried about receiving it. Disinfectant use kind of goes up with the hand washing and gloves, again, trying to destroy the virus that's on a surface. And how about how do we destroy it after the body, enters the body? What do we do? Well, again, there's things one can try to reduce the chance that it's going to be active once it enters the body, and that is number one, your personal immune fitness. So how well are you immunologically? How is your sleep? How is your nutrition? How is your stress? How is your exercise? So these are all components of personal immune fitness. So if you're somebody who's stressed out, somebody who's sleeping poorly, who's eating terrible foods that are highly inflammatory, who's not exercising, not moving blood through your body, you're really having very low personal immune fitness, and in doing so, you're going to be at increased risk for contracting the virus. Supplements and nutraceuticals, I get this question a lot as a functional and integrative medicine doctor. People say, well, hey, Dr. B, what can I take? What pill can I take that will help me reduce the chance of getting this virus? And I think that's part of the both the blessing and the curse of Western medicine is that so many things have been treated with pills and so many conditions have been treated with pills and with drugs and so on, that our society has begun to believe that everything can be fixed by a pill and everything can be cured by a drug. And it's just a matter of taking a pill or taking a drug and the problem goes away. And that leads us into the last part of this, which is vaccines. Vaccines have never, in the history of mankind, ever been 100%. The best we've been getting is with the measles vaccine at about 94%. So even the measles vaccine isn't 100% in terms of preventing disease. But this has been the promise again, part of the downfall, that people believe that once you've got the vaccine, that resolves all the issues, and you go back to doing what you're doing before, and the answer is no, you can't. And why? Well, let's first look at vaccines. We've had vaccines around for quite a long time, and people are usually surprised to realize that really we've been dealing with vaccines since the late 1700s. And again, people, everyone wants to believe that whatever there was that was good happened in the last 10 years. And no, we've had vaccines for quite a long time for quite a lot of different conditions. And how they work is that they work to really get the body to produce the proteins, these antibodies we call them, to attack either the foreign invader, the bacteria, the virus, or the toxins that those bacteria or viruses produce. So what we're really doing is we're just helping the body kind of ramp up or accelerate the process of elimination of either the virus or the toxin. So they don't act independently of us, they act along with us. The most common vaccine types we have out there are the inactivated virus. So this is a virus that's been basically essentially killed. And we know that this killing process is not 100%. That's why some people who get the flu vaccine can actually get a very mild case of the flu. There's a live attenuated virus. And this virus, I like to kind of compare it to think of the live virus of let's say, COVID-19 as a 19-year-old high school student who's playing football. I mean, he's big, he's tough, he's amped up on sports, he's, running around. If you look at him sideways, you might be getting into a fight. Okay, that's the live COVID virus. A live attenuated virus, that's the married guy who's about 40 years old, he's got 3 kids, he's trying to watch TV. He's got the football game on, but the wife's giving him a to-do list, and the kids are pulling on his hair, and so he gets off the couch and starts doing the to-do list and starts changing diapers. Okay, that's the live attenuated virus. And so what happens is that when you have this live attenuated virus, you use this live attenuated virus to make the immune system think it's being attacked by the 19-year-old kid, so that it mounts that immune response that is as aggressive as it was if it was being attacked by the live virus. The viral component vaccine is taking a piece of that virus or a piece of that bacteria, and it uses oftentimes the protein coat that surrounds the RNA or DNA or a piece of it, and it uses this component to produce antibodies, these proteins, against that component. And now you go ahead and produce these antibodies against that component, which then, of course, attacks the live virus when it's in you. There's toxoid administration. That's, again, the toxin that can be produced. So you produce a vaccine against that toxin only, but not against the actual organism. Viral vectors, they've been around for a while, since 1970s. And they typically use what's called an adenovirus. And the adenoviruses are also very common in the population. They are seasonal viruses typically in humans. There's also adenoviruses in chimpanzees and other species as well. And the idea is that we know adenoviruses really well. So we've been able to genetically manipulate adenoviruses to become basically, live attenuated viruses, but they have become so peaceful and kind of docile, they really don't do anything in the body but transfer the component part of the virus you want to have antibodies made against into the cell. So they're a carrier. They're like the mailman. They come up to the door, they knock on the door, and in your mailbox, they drop your mail. Well, that's what's happening with these viral vectors. The adenovirus is the mailman, and the DNA or the RNA, in this case, the RNA from the COVID is now dropped into your mailbox, into your cell. And so when you check your mailbox, you grab your mail, you take it inside the house. Well, your body takes this mail from this COVID-19 RNA, takes it into the house, your cell, and produces antibodies against this RNA. Or I should say your body makes the antibodies against the RNA. The most recent viral vaccine type that has come to light is the messenger RNA, or that's the mRNA. And that's the newest member of this family. But it's not that new. I mean, they've been studying this for a number of years. They looked at it for Zika, for rabies, for what's called CMV or cytomegalovirus. So they've been looking at RNA viruses for quite a while. They've done a lot of animal studies, what's called DART studies, looking at animals in pregnancy with mRNA viruses. And in fact, the company Moderna actually started 10 years ago, 11 years ago now, they started primarily as a company, as a venture capitalist company, to produce only mRNA viruses. So that's how Moderna actually got started, was making these mRNA viruses. And the way they work is that you now have this viral, again, reproductive information, this blueprint in the RNA, and this blueprint gets carried into the cells there's different lipids or fats around this information, and this information gets absorbed into the cells through the vaccine, and once inside your body, this mRNA is a blueprint, and it uses your cell's machinery to make the protein that this blueprint codes for, and that protein happens to be the spike protein that's found on the outside of the virus. So now your cells are making a piece of this virus. Now, they're not making the whole virus, so there's no, let's not get confused here. You're not making the virus. You're making only the spike protein on the surface of the virus that is what allows that virus to hook into your cells and to reproduce itself. You're only making that one protein, and that can't infect anybody. But what it does do is when your cells make it, that protein goes to the surface of the cells. It goes out into the circulation, where your body sees it as being foreign. It shouldn't be in your circulation, and so it produces the antibodies against that spike protein. It's those antibodies that then will attack the real virus when it tries to enter your body. They will attack the spike protein that's on the surface of the real virus, and that helps to eliminate it from your circulation. So if you have questions about that, of course, I'm always free to ask or answer questions for you at the end. So whose COVID vaccine does what? The mRNA virus, Pfizer and Moderna. Viral vector, again, that's the adenovirus. That's Johnson & Johnson distributing the Janssen virus, AstraZeneca. What's interesting is Sputnik 5. Sputnik 5 is the Russian version of the J&J virus vector. What it does, a little different than other ones, because it uses two different viral vectors. So J&J came out and they said, well, this is a one-shot deal. So did AstraZeneca. Sputnik never was a one-shot deal, and it's also a viral vector. What they did is they said, well, so we're going to use one virus to give you the initial infection, and then for theoretical reasons, and we can get that later if you'd like to, but for theoretical reasons, we're going to do a second viral vector for a booster shot. So Sputnik 5, actually, it's a very effective virus, more effective than the J&J vaccine is, but that's made by Russia. The inactivated is basically where they try to kill the virus, again, through different means, and that's made by Sinovac, which is a Chinese company. So how effective have the vaccines been? And the reality is that these vaccines, especially the mRNA vaccines, we had no idea how well they were really going to work. There was really no way of predicting to any great degree what they would do with this particular COVID virus. And when the initial studies came back showing 90+% effectiveness, the people in the drug companies are absolutely beside themselves with excitement because they had no idea that they were going to have such a great response for this particular viral vaccine type. The viral vectors, on the other hand, are about 60% effective, a little bit more. And over time, we've kind of found that both these numbers may be a little generous. Maybe the viral vectors are closer to 55, 58. Maybe the mRNAs are closer to 85, 88. But nevertheless, much, much greater than most other vaccines that we give to people on a regular basis. Well, how long do they last? Again, a lot of the information we're talking about today is in the process of evolution. As time goes by, as months go by, as years go by, we're going to be getting more and more information about all these questions. And these answers might change. We might find some new answers that we didn't expect, or we might find some solidification of data that we already have. But in terms of the immunity with the vaccinations, they appear to, the antibodies appear to be present for at least 5 to 6 months. Maybe longer in smaller amounts in some people, maybe shorter in other people. We don't know what this means. So what we don't know is if somebody has non-detectable or minimally detectable antibodies at 7 or 8 months, does that mean that they don't have resistance to the viral infection? Again, we don't know. The common belief is that there should be enough antibody present to stimulate a repeat response to the infection should it return, but we just don't know how good that response will be. So currently the recommendation is to get a booster vaccination at about 6 months or so after the second course of the first vaccine type, the mRNA, or after the single dose of the viral vector vaccine from, for example, Johnson & Johnson. So these are recommendations based without a lot of data behind them, not really knowing what is the ability of that vaccine to go beyond 8, 9, 10 months, even though we can't measurably check its antibody titers. Natural infection, we do believe that antibody lasts a little bit longer than the vaccination does, and this is true for a lot of vaccines versus natural infections, but we don't know how long. And again, the idea is that if the person had a very severe case of COVID, then most likely they're going to have a much greater antibody response, and more likely than not, they're going to have greater protection for a longer period of time than if somebody had a very mild infection. So a lot of people worry about the vaccine. They're nervous about it. They heard that it's a new type of vaccine. They've heard that it's never been done before, all these things. Again, no, we've never had a mRNA vaccine against COVID. That's true. But again, there's data, there's a lot of animal data to its relative safety. And yes, the fact that we have now given it to over 5 billion people worldwide, it is the single largest human experiment with a vaccination type. And I think that certainly the good news of all that is that, of course, we do have 5 billion vaccine doses that have been administered, so we have lots of data to look at now in retrospect. And what we're finding is that there are some short-term and very mild complications. I don't know that I would call it a complication as much as I'd call it just a reaction to a vaccine. So we get this also with people who have the vaccine for a whooping cough or the vaccine for tetanus and so on. You can get, of course, injection site soreness and redness, sometimes pain is there as well, sometimes a low-grade fever, sometimes body muscle aches and pains. What's interesting is the menstrual irregularities, and I've seen this for a number of patients who have had the vaccine who have told me that after the vaccination they did have some menstrual issues that occurred afterwards, which were not occurring prior to the vaccination. This has not really been well highlighted in the literature, and there are currently 2 physicians that are studying this. They've accumulated about 150,000 patients with menstrual irregularities that they're trying to really determine what amount or what degree of this vaccine has to play in those. Short-term severe complications, these are very few and far between. And we're talking about 4 to 4 cases for 2 million people or even less, but we have myocarditis. There's, of course, the pericarditis, this is inflammation of portions of the heart. TTS is probably the most serious one of the bunch, and that's the, again, thrombotic thrombophilia syndrome, or not thrombophilia, but thrombocytosis, or thrombocytopenia rather, syndrome. And what this is where people will form blood clots unexpectedly, and they'll also have low platelet counts, which is thrombocytopenia. And this can, in fact, be deadly. That's probably one of the more severe short-term effects. And I think this is what scares everybody, because when they hear about TTS, they begin to get very nervous about it. They can be very worried about it. But really, it seems to be limited primarily to patients under the age of 50, and more so in women than in men. Whereas the myocarditis, pericarditis is more in men than in women, and for mostly men who are between the ages of 18 and 30. So again, we do see that some of these vaccines have a different affinity to cause different kinds of reactions based on the person's age and gender. But in general, these are very, very limited. So, other short-term severes might be a Guillain-Barré and so on, and of course, anaphylaxis. Long-term complications, and this is what I get most questions about in my practice is, great, this is wonderful, yeah, we know about the vaccine. What's the long-term implication? What's the long-term effect? Well, we know that, again, with 5 billion vaccine doses already given, that these short-term effects, both the mild and severe, are very few and far between. And they're much less severe on many levels than the actual infection itself. The long-term vaccine complications, well, so far we don't have a long-term. You have to realize the vaccine has not been out for that long. We're talking about people who received their first vaccine a year ago or less, so we don't have 3, 4, 5 years to tell you what a long-term complication is going to be, but we don't have anything right now that appears to be going on that's going to be considered a long-term issue. I mean, there are theoretical impacts on testes or the ovaries. There's some theoretical concerns about pregnancy loss or infertility. These are primarily related. Let me see if I have my next slide. I do not, so I'll go back. Those are primarily concerns based on some theoretical data looking at what's called antibody modeling, where they take a computer and they look at sites on the virus, on the antibodies, and they try to look to see, can we produce antibodies against our own body parts? Because the antibodies being produced against the virus is potentially going to cross-react with our own body tissues. And we do see that with a lot of infections, actually. We see many viral infections or even bacterial infections can have this cross-reactivity. It's called mimicry, where basically your body has a protein component on a cell that might be very similar in terms of how it looks to a protein component on the virus. And your body, when it produces an antibody against that protein component on the virus, can't then differentiate between that protein in the virus and that protein on your cell. So sometimes that antibody attacks your cell. And so it creates this autoimmune response. And that's part of what kind of happened with COVID is there's been some modeling of these sites, what's called antigenic sites. And the concern is, well, gosh, we can have a computer generate all these different configurations of these proteins, and it looks like, we've got 24 proteins here that could cross-react with certain proteins that are found not only in the ovaries and testes, these that produce the germ cells or the sperm and the egg, but also against parts of the placenta. And there's a protein in that placenta that allows the placenta to implant into the endometrium and to grow. And this syncyte 1 protein, it appears that, gosh, it looks like these antibodies could lock onto this syncyte 1 protein and cause maybe a pregnancy loss or maybe some infertility issues. So this is where a lot of people have really pulled back from getting the vaccination because of what they're reading about, what they're hearing about is these computer-generated models and these potential cross-reactivities with our own native proteins. The good news is that there's a process in place to monitor for this sort of thing. It's the AEVRS, which is the Adverse Events Viral Recording System, and it's supposed to allow people the ability to report adverse events related to either a virus or to a vaccine. And so most time people aren't going to call in about the virus, but they're calling about a vaccine. So really it's more of a vaccine kind of monitoring process. And what will end up happening is that if somebody has something that they think is related to the vaccine, a miscarriage, for example, or they might have an issue with not getting pregnant, they can always contact the AEVRS system, it's a government system, and make that claim, and then, of course, that would then be investigated to see if there's any merit to that claim. So far, with the AEVRS system, we have not had any issues related to the vaccination in patients who have been pregnant, patients who are expecting to get pregnant or trying to get pregnant, compared to what's called the background rate. So there's always a background rate of events that occur in anybody who's trying to get pregnant, and that's background infertility, that's background pregnancy loss, that's background preterm labor, all those events. And we haven't seen anything based on AEVRS reporting. Well, so the vaccine scares people. What should scare people more is COVID complications, both short-term and long-term. The short-term complications can be quite severe. Now, you can be something as asymptomatic as someone walking with a little bit of sniffle or maybe a loss of smell or taste for a short period of time. Or it could be hospitalization. I mean, someone who goes into the hospital and is admitted. Maybe they're on ECMO. Maybe they're on dialysis even. So, again, someone with severe short-term process. And, again, this can be quite devastating, both to the individual and to the family. So these patients oftentimes require medications, especially if you're hospitalized. So remdesivir is an antiviral, and that's usually given to try to reduce the chances of admission. There's also monoclonal antibodies. There's a serum, which is called convalescent serum from previously infected people. People might need to be intubated. Antibiotics might need to be given. So there's a lot of things that can happen quite significantly in the short term for people who have COVID. The long term, you never really talk to people about that. You don't hear about it, but there's a group called long haulers. And these long haulers are people who've had COVID infections and now have persistent symptoms. And those persistent symptoms could be exhaustion, memory loss, headaches, confusion, issues again, related to their primary infection, how they felt initially. And they're saying that those long haulers may be as high as 8 to 10% of people with COVID infection. So these aren't people who have a short-term problem, but now they've got a long-term problem. And sometimes that long-term problem can lead to continued organ dysfunction, AFib, cardiac arrhythmias, pulmonary problems with breathing, asthma, and so on. Well, the most significant long-term problem is death. And I think that people kind of forget that the chance of dying from a COVID complication is not insignificant, and it is significantly greater by multiples of magnitudes higher than any of the risks associated with the vaccination. So let's cover the pregnancy and fertility, because I think this is what a lot of people want to hear about. Okay, now you know about the background, about the COVID, about the vaccine, all that kind of stuff. So when or should you get the vaccine? Now, to me, I'm a believer in the concept of autonomy. So people, as adults, should be able to make a decision on their own whether or not they want to, do something to their body. And that's really a huge debate in our society right now, and it's outside the scope of this presentation. But I think that, if you're asking me at this point, I think that everybody should get the vaccination, and when they should get it, at this point, they should get it as soon as they can. If you asked me this question a year ago, I would have said more hesitantly, probably hold off on the vaccine for now. Let's kind of wait and see what happens. At this point, I think we have enough vaccine doses administered. I think we have enough data to show the benefits of the vaccine versus natural infection. We also have enough information to show the benefits of the vaccine, not only against the original COVID-19, but against the variants as well, and the reduction both for hospitalization and for death. Okay, that reduction is dramatic. So I think that it should be now, and I think it should be everybody. So what are the risks for implantation or infertility? And again, there are some studies, I'll show those coming up, that there really have been shown to be no risks for implantation or infertility regarding the vaccine itself. There are, again, the theoretical risks we talked about earlier related to protein modeling. There's the discussion about the ACE2 receptor binding, and maybe because of this receptor binding, it's going to cause problems with the proper development and maturation of the egg inside the ovary. Again, we haven't seen this. There's a concept called cellular autophagy, which is affected by the COVID virus. This is where the cells try to basically purge themselves of build-up material so that they can, again, stay healthier. COVID infection reduces the ability of the cell to produce its autophagy response. And the idea being that by doing that, it's going to impact the maturation of cells and, again, possibly lead to infertility. Again, that has not been borne out. And the last part, of course, is the molecular mimicry, which we already talked about, which describes the fact that antibodies can be produced against the body's own tissues. But we haven't seen this. We've only been able to theorize that it could happen with COVID, but we haven't seen this. And the important thing is not what's theoretical, but what we're actually seeing, what's actually happening out there. The studies to date are very reassuring. So not only have we not seen it with the AEVRS reporting, but there have been some studies that have been done. Dr. Morris reported in the Fertility Reports back in June of this year that they did IVF transfers of patients' embryos in women who have had both the COVID infection and those who have not had the COVID infection, and they showed no difference in miscarriage rates. Dr. Gray published in March of 2021 that there was no complications in pregnancy, looking at 30,000 plus women who have been infected with COVID or the vaccination, again, compared to a background rate. And Dr. Shivabook's publication in June of 2021 looked at the AEVRS reporting system and showed, again, no adverse events in over 35,000 women who are vaccinated. We now have over 150,000 women who have been vaccinated here in the U.S., and the number is climbing. And again, no increase in reports to the AEVRS system with respect to background rates. There is an ongoing mom-vax trial that started enrollment just last month, or actually 2 months ago in July. And again, that's an ongoing study to try to really put to rest any more questions regarding the concerns of women who are pregnant and the vaccine. So what we really need to address is what are the real-world risks of COVID infection? And I think this is the important thing that we keep missing. There's a lot of conversation around the theoretical risks of the vaccine. I think most of them have been put to rest now with, again, as many billions of doses that have been given around the world of all different types of manufacturers. I think we know what the short-term risks are going to be. I think the long-term risks now are very hypothetical because we're not seeing anything developing, and in the studies that have been done to date, we're not seeing any impact on fertility, miscarriages, etc. But we know that during pregnancy, we see an increased risk for miscarriage in patients with several viral type infections. So we know that viruses can cause miscarriage. We're not quite sure if COVID does that yet. There are some reports saying yes, there are some reports saying no. We do know that with COVID, you're going to have an increased risk for a smaller baby, which is SG or IUGR related to inflammation of the placenta and the body's response to the infection. We also know there's a high risk for preeclampsia or gestational hypertension, again, the body's response to the infection. We also know there's an increased risk for preterm labor or preterm birth because of the infection. And I just had one of those patients myself last year who we had to deliver prematurely, not because we wanted the baby to come out, but because the mother was doing so poorly with her COVID infection that we realized that we needed the baby to be out to allow her body to respond better to the treatments for her COVID pulmonary involvement, and reduce the risk of her being intubated and going up to the intensive care unit and potentially dying from her disease. So we produced a preterm birth to save the mother, but now we produced a baby that ended up in the NICU because, again, it was born prematurely. And this would not have happened had she not had COVID or the vaccine. So the real-world risks are very small. Again, TTS is probably the most significant one, and that's primarily with the viral vector vaccines. Again, the cardiac issues, again, primarily limited to males under the age of 30. So again, very small risks, very limited groups of people. When you get the vaccination, and again, as I said, anytime. So whether you're pregnant, whether you're not pregnant, whether you're breastfeeding, whether you're not breastfeeding, whether you're intending to get pregnant, vaccination will be potentially life-saving, and it doesn't matter what age range you're in. I always hear the same story. If you're over 60, that's the problem. If you're under 60, don't worry about it. The variant, the Delta variant in particular, is changing the entire playing field. So we're going to continue to get variants. They're going to come out there and change the playing field. There are now 13 or more variants that we're closely watching that are around the world that are developing. And again, any one of those variants can become the next Delta variants in a more severe form. So there's a lot of unresolved issues, and because of these unresolved issues, we oftentimes find a lot of discussion and a lot of refrain from doing the right thing. And those issues, of course, are, well, how many boosters am I going to need? Was the vaccine really working? How about these variants? How effective will this be over time? How often? How many times should I get these vaccinations? So is it a one-time deal? Gee, there aren't enough studies out there. I'm having a hard time really believing that this is safe during pregnancy. I mean, I get this over and over and over again. And I think that really, at this point, the time has really come for us to really put aside these concerns and realize that vaccination is safer than the infection. It's certainly safer than the variant infections. And the less people go for vaccination, the more likely they are to get infected. And the more likely they are to get infected, the more likely they are to spread it to other people, including those who have been vaccinated. Remember, science is a process of ongoing education. It's a changing, evolving landscape. Things that were true in science 50, 100 years ago may not be true today as we learn more. So we cannot stop moving forward and making progress simply because we don't know everything there is to know. I mean, if we did not use penicillin back in the 1950s, there would be untold deaths from hundreds and thousands of people until we knew all the risks and all the benefits of penicillin. The same thing is true with COVID. You know, if we keep waiting for 4 and 5 years for all the data to come out so we feel 100% sure we know exactly everything about it, we're going to literally have millions of more people suffering needlessly and dying needlessly. So this is who I am. If you want to reach out and ask me questions, I do have telemedicine appointments available. Again, we can have a conversation regarding anything patients want to talk about related to medicine. I'm on telemedicine appointments. I'm also available in the office as well. I'm here in Mission Viejo.